I'm very honored to be here. So today I will present the gynecological session on endometrial cancer. So what is new in 2023 in endometrial cancer management? These are my disclosures. So the session objectives are to determine the indication for radiation therapy and systemic therapy in non-metastatic endometrial cancer, to understand the role of molecular markers and their potential impact on treatment, to interpret the findings of two new clinical trials published in 2023 on the role and efficacy of the addition of immune checkpoint inhibitor in locally advanced and recurrent endometrial cancer, to determine the optimal management treatment for recurrent cancer, to assess the post-treatment surveillance regimen, and last, to assess the feasibility and toxicity of ultra-hypofractionation in introduction. Endometrial cancer is the fourth most common cancer, representing 7% of estimated new cases in the United States. There's approximately 13,000 deaths, and the incidence has risen in the last 30 years, reflecting a rise in the prevalence of risk factors such as obesity and aging population. It's interesting to note that there's a doubling in cases in women less than 40, which now accounts for 4.2% of all low-grade endometrial cancer in the United States. These are the risk factors: obesity, diabetes, high-fat diet, which increases the levels of estrogen, early age at menarche, nulliparity, late age at menopause, Lynch syndrome, ages between 55 and 64, and tamoxifen use. There are profound racial disparity among patients with endometrial cancer. When assessing adherence of NCCN guidelines, Black, Latina, and American Indian or Alaskan Native women have lower odds of receiving adjuvant treatment, while Asian and Native Hawaiian or Pacific Islander women have higher odds of receiving adjuvant treatment compared to white women. Even in equal access healthcare system, Black women had worse outcomes compared to non-Hispanic white women. Tumor molecular differences have been reported in the Cancer Genome Atlas. Serous subtypes and TP53 mutations were more frequent in Black or African American women. So concerning the staging, lymphadenectomy was not associated with survival benefit based on two large randomized trials. Surgical staging provides prognostic information to accurately stage and guide adjuvant treatment. NCCN and ASTRO consensus guidelines recommend sentinel lymph node mapping over standard pelvic lymphadenectomy. And ultra-staging only is done if the H&E are negative and there is myoinvasive carcinoma. On the right, you can see the principle of evaluation and surgical staging when sentinel lymph node mapping is used. Of note, if one side does not map, a site-specific lymphadenectomy is performed, and if any nodes are suspicious, they should be removed regardless of the mapping. So at SGO this year, there's a new FIGO staging, which has not been published, and these are the slides from the meeting. So as you can see, now stage 1A is divided in three, which accounts for the histology and extent of LVSI. So this is new in endometrial cancer, that now the extent of LVSI will change the stage. For 1B, it also includes the extent of LVSI. Stage 2 is also divided into three based on the histologic type, and the divided. This is for stage 4, as you can it depends on the site of the molecular classification into the staging. So now we have to mark it as a to denote the addition as note here. You can see M for molecular classification. For example, you can see here stage 3M P53 abnormal. So this is all new. We are looking forward to the publication of the staging to have further information. So there are 4 patterns of myometrial invasion. The first one is single gland pattern, which is the most common pattern. It is associated with poor prognosis. The second type is the pushing expansile pattern, associated also with good prognosis. I'm so sorry. The first one is with poor prognosis. The second one is with good prognosis. Adenomyosis-like should not be confused with adenomyosis, and it is associated with good prognosis. The fourth pattern is the microcystic elongated and fragmented pattern, which represents between 6 to 48% and is strongly associated with low-grade endometrial carcinoma and mucinous differentiation. In a recent study, tumor slides of approximately 1,000 patients with high intermediate risk endometrial cancer from both PORTEC 1 and 2 were reviewed. MELF pattern was found in 13.1% of cases and was associated with grade 1 and 2, deep myometrial invasion, and substantial LVSI. Most MELF pattern tumors had no specific molecular profile, and MELF was not found to be associated with risk of recurrence after correction for clinical, pathological, and molecular factors. The European guidelines support molecular classification for endometrial cancer, and their guideline integrates the molecular classification into the adjuvant treatment algorithm. There are 4 molecular subgroups based on genomic abnormalities that reflect tumor biology. Typically, polymutation tumors are associated with an exceptionally favorable prognosis with only rare relapse, regardless of adjuvant treatment. MMR deficient comprises about 25 to 30% of all endometrial cancers and is defined by the loss of nuclear expression of one or more mismatch repair protein, leading to an accumulation of mismatches, insertions, and deletions. P53 mutated comprises 25% of tumors. They're predominantly of serous histology and are associated with poor clinical outcomes. No specific molecular profile, also referred to as copy number low endometrial cancer. Prognosis in these tumors is stage dependent, but together can be regarded as intermediate risk. These are the 10-year results of the PORTEC 2 trial. 427 patients with high intermediate risk endometrial cancer were analyzed. The right graph shows the cancer-related survival based on the molecular subtype. As you can see, polymutation resulted in a 10-year cancer-specific survival of 100%, while non-specific molecular profile was a little lower at 96.2%. MSI, the overall survival at 10 years was almost 85%. And those with P53 mutant tumors had the worst prognosis and outcomes with 62.3% cancer-specific survival. On the left graph, this is the risk of pelvic recurrences, which correlates to the adjuvant treatment. Based on adjuvant treatment, patients treated with vaginal cuff brachytherapy for unfavorable features had the highest risk of pelvic recurrence. So what are the indications of adjuvant therapy in non-metastatic endometrial cancer? This is case number 1. 58-year-old postmenopausal female presents with vaginal bleeding. She had surgery and sentinel lymph node mapping bilaterally. Pathology revealed endometrial carcinoma grade 2 with 25% myometrial invasion, no LVSI, cervix tubes and ovaries are negative, and 4 sentinel nodes were negative. What is your treatment recommendation for this patient? Vaginal cuff brachytherapy alone, observation, pelvic radiation, or combination of pelvic radiation and vaginal cuff brachytherapy? For low-risk endometrial cancer, based on two studies, the Sorbet study and the Danish trial, there is no benefit for adjuvant radiation in these patients. In the first trial, they compared 645 patients with low-risk endometrial cancer, randomized between vaginal cuff brachy versus observation, and the vaginal recurrence rate were not significantly different between the two. In the second study, the local regional recurrence without adjuvant treatment was 6.3% at 14 years. The remission rate was 100% for patients with low intermediate risk who developed vaginal recurrence and were treated with curative intent. So despite the increased recurrence rate, there was no impact on long-term survival. This is based on the ASTRO consensus guidelines. So as you can see here, recommendation number 1. So for patient with FIGO stage 1A, grade 1 or 2 endometrioid carcinoma without intermediate or high risk factors, adjuvant radiation is not recommended. The intermediate risk factors are age over 60, focal LVSI, and the high risk factors include substantial LVSI, especially with surgical, without surgical nodal staging. So for this patient, we would recommend observation. Case number 2 is a 61-year-old patient who had endometrioid carcinoma grade 2 on biopsy. She had surgery, which confirmed endometrioid carcinoma grade 2. There was 14 out of 20 millimeter myometrial invasion, no LVSI, sentinel nodes were negative. So what is your treatment recommendation? External beam, vaginal cuff brachy, a combination of external beam plus brachy, or observation? So this is the PORTEC-2 study, which is a non-inferiority randomized controlled trial comparing pelvic radiation to vaginal cuff brachytherapy in high intermediate risk patients. There was no difference in the vaginal recurrence at 5 and 10 years. The 5 and 10-year pelvic recurrence were higher in the vaginal brachytherapy group, but did not translate into difference in overall survival. Based on the ASTRO guidelines for this patient, patients without high risk factor with stage 1B grade 1 or 2 or myoinvasive stage 1A grade 3, we would recommend vaginal cuff brachytherapy. So for this patient, vaginal cuff brachytherapy would be the preferred approach. Another case, very similar to the case number 2, the only difference is that this patient had substantial LVSI. So does that change our approach? So what is substantial LVSI? So the extent of LVSI is the strongest predictor for recurrence disease in patients with stage 1. In a pooled analysis of PORTEC-1 and PORTEC-2 trials, samples of almost 1,000 patients were analyzed. A 3-tier semi-quantitative assessment was defined, and substantial LVSI was found to be the strongest independent prognostic factor for pelvic recurrence, distant metastases, and overall survival. Defining the extent of LVSI is crucial, and many definitions have been used. The cases in PORTEC-1 and 2 were analyzed, and data was validated on an independent cohort. The optimal trade-off was found when at least 4 or more LVSI positive vessels are present. This is the 5-year pelvic lymph node recurrence risk correlated with the extent of LVSI. As you can see, when 4 or more vessels had LVSI, the 5-year recurrence rate was 26.3% compared to 6.7% for focal and 3.3% for no LVSI. As per the ASTRO recommendations, patients with high risk factor, substantial LVSI, who have stage 1B grade 1 or 2 or myoinvasive 1A grade 3, external beam is conditionally recommended. So for case number 3, we would recommend external beam radiation. So what is the role of adjuvant external beam? 3 randomized trial and meta-analysis established the role of EBRT in high intermediate risk endometrial cancer with local regional benefit, which did not translate into overall survival. So for patients with FIGO stage 1B grade 3 or FIGO stage 2 endometrioid carcinoma, EBRT is recommended. This is the treatment algorithm for endometrioid carcinoma. This is from the ASTRO guidelines. And as you can see, based on the intermediate or high risk factors, we either recommend brachytherapy, external beam, or observation. And this is from the published study. So concerning high-risk histologies, there's a lack of randomized trials specifically evaluating the role of adjuvant radiation in high-risk histologies. In GOG 249, which is a phase 3 trial, patients with stage 1 and 2 were included with the same risk factors as GOG 99 and randomized between pelvic radiation versus brachytherapy and 3 cycles of carbotaxol. The primary endpoint was recurrent-free survival. 15% had Pap serous and 5% had clear cell carcinoma and were included. The 5 years recurrence-free survival, vaginal and distant recurrence rate were similar between the 2 arms. However, pelvic or periaortic nodal recurrences were more common with vaginal cuff brachytherapy. And these are the curves for recurrence and overall survival, showing no difference. In PORTEC 3, 16% had serous cancer in each arm. Significant improvement in overall survival and recurrence-free survival in the chemoradiation arm was found compared to radiation alone, with an absolute benefit of 19% in overall survival and 12% in recurrence-free survival. Clear cell carcinoma is rare. It is associated with higher stage and increased risk of recurrence and relatively chemoresistant. In a retrospective study including 71 patients with stage 1 and 2 clear cell carcinoma, 82% received adjuvant therapy, including chemo in 61%, radiation in 70%, and 49% had a combination of chemo and radiation. Recurrence-free survival was not different among patients receiving no or less than 6 cycles of chemo versus patients receiving 6 cycles of chemo. However, the median overall survival was higher in the patient who received 6 cycles of chemo compared to those who got less than 6 cycles of chemo, which is interesting because we assume that it is chemo resistant, but in this study, patients had a better overall survival when they got the full 6 cycles of chemo. So what are the molecular marker prognostic value for clear cell carcinoma? In a meta-analysis including 136 patients, the 5-year overall survival was highest for patients with defect in MMR, while those with P53 mutated and P53 wild type had similar outcomes. This suggests that clear cell carcinoma MMR deficient could be considered similar to MMR deficient endometrioid carcinoma, whereas those that had P53 either wild type or abnormal had worse outcomes. And this is the algorithm for the high-risk histology based on the ASTRO consensus guideline. So what are the recommendations? So for patients with myoinvasive FIGO stage 1A high-risk endometrial cancer, vaginal brachytherapy with or without chemo is conditionally recommended. For those with stage 1B or 2 high-risk histology, endometrial carcinoma, EBRT with chemo is conditionally recommended. So that brings us to case 4. This is a 65-year-old patient with stage 1B grade 3 endometrioid carcinoma of the uterus. She had THBSO and sentinel lymph node biopsy. LVSI was extensive. 10 lymph nodes were negative. Margins were negative, and she had no adnexal, serosal, or cervical involvement. Which of the following treatment options do you recommend? chemotherapy alone, pelvic radiation plus chemo, pelvic radiation, or brachytherapy alone. So this brings us to review PORTEC-3, which is a randomized trial that looked at patients with different eligibility criteria. So they included stage 1B grade 3 endometrioid, 1A grade 3 with LVSI, stage 2 to 3 endometrioid, and stage 1 to 3 PAP or clear cell. And they were randomized between adjuvant radiation alone versus chemoradiation with 2 cycles of cisplatin followed by 4 cycles of carbotaxol. The 5-year overall survival adjusted for stratification factors was 81.4% in the chemo-RT group versus 76.1% in the radiation alone group. Similarly, the 5-year failure-free survival was 76.5 versus 69.1. There were more distant recurrences in the RT alone arm. Specifically, stage 1 and 2, no difference in overall or freedom failure survival was seen. These are the curves. As you can see, there was no difference for stage 1 and 2. What about GOG 258? So a very similar study, but different arms and different inclusion. They looked at chemo-RT versus chemo alone, and they included mainly stage 3 and 4. Stage 1 and 2 compromised only 2% of patients, and clear cell and PAP serous only 3% of the population. So patients were randomized between chemotherapy alone versus chemoradiation. So there was no difference in the recurrence-free survival at 5 years. The 5-year incidence of vaginal recurrence was highest in the chemo alone, and there were more pelvic and periodic recurrences in the chemo alone arm. Distant recurrences were higher in the chemo-RT arm. And so based on those 2 trials, what do we recommend? So for stage 1 and 2 endometrioid adenocarcinoma, systemic therapy is not recommended because there was no benefit for these patients. So this is case 4. This is a patient with stage 1B grade 3, as we discussed. So as discussed before, she had extensive LVSI. There was no benefit to add chemo based on those 2 trials. So so radiation alone is the preferred approach. For locally advanced endometrial cancer, we reviewed the 2 trials, PORTEC-3 and GOG 258, and they both established the role of adjuvant chemotherapy and radiation therapy, especially in stage 3 and 4 endometrial cancer. In PORTEC-3, the hazard ratio was 0.61 failure-free survival and 0.63 for overall survival, favoring chemo-RT arm. There was no difference in the GOG 258 in recurrence-free survival and overall survival. However, there were more vaginal, pelvic, and periodic recurrences when radiation was omitted, and there were more distant recurrences in the chemo alone group, which is probably due to the fact that 4 cycles of chemo might not be enough for those patients. So that could explain a little bit why the distant recurrences were higher in the chemo-RT group. So the third recommendation, so for patients with stage 3 and 4A endometrial cancer, adjuvant systemic therapy is recommended. What about the sequencing of adjuvant therapy? There is no randomized trial. We have strong data for concurrent chemo-RT based on 2 phase 3 and 1 phase 2 trial. So PORTEC-3 and GOG 258, they have the most published schedule with complete follow-up, toxicity, and quality of life data. So what about sequential chemo followed by radiation? So this is a study by Signorelli, which is a retrospective study. Patients either got observation, chemo, radiation, or a combination of chemo and radiation. So chemo was delivered first, followed by radiation, which, as you can notice, was only 16.5% of patients. After a median follow-up of 100.1 months, sequential chemo-RT improved disease-free survival and overall survival in stage 3 patients. So there are pros and cons for sequential chemo and radiation. The pros is that it treats microscopic distant disease that is already present. You can give more than 4 cycles without damaging or giving too much toxicity to the bone marrow. And it is favored for patients with high risk of distant disease, such as fallopian tube and ovarian involvement, serosal involvement, or high common iliac or periaortic nodes. The cons is that it delays local treatment, local therapy, and it could result in poorer local regional control if radiation is emitted, especially for those with cervical involvement, pelvic adenopathy, and positive margins. What about sandwich approach? Well, it is well tolerated. There's a lot of data out there. It was not included in any phase 3 trials, and the data is mainly based on small phase 2 retrospective study with short follow-up. Although it is commonly done in practice, there's limited data to make recommendation. This is a multi-institutional retrospective trial that looked at exactly this question: which sequencing should we be using? Included only stage 3C endometrial cancer. Patients were either treated with upfront chemo, sandwich, concurrent chemo-RT, chemo-break, or upfront radiation. And as you can see from the curves, either on the left, recurrence-free survival, on the right, overall survival, there was no difference in the sequencing approaches. So this is the algorithm from the ASTRO guidelines for stage 3 and 4, all histologies. So whether we prefer upfront radiation for the patients with high risk of pelvic failure, we can even give it concurrently, followed by sequential chemo. If we prefer to address the distant disease, for example, with serosal or fallopian tube involvement, we can give chemo first and then give radiation after. Case 5. So this is a 74-year-old patient with stage 1B grade 2. She had ITC in 2 nodes and no LVSI. So what is the appropriate management approach for this patient? Pelvic radiation, vaginal brachy, concurrent chemo-RT, or sequential chemo-RT? So what is ITC? It is metastatic carcinoma in the form of microscopic clusters and single cells, fewer than 200 cells, measuring less than 0.2 millimeter. It is associated with MELF and LVSI. So these are the first study on the left is a prospective trial, which included 519 patients with sentinel lymph node metastases. The 5-year progression-free survival for ITC was 95.5%, similar to node negative and micromets. And if you look at the 3-year progression-free survival for macrometastases, it was much lower at 58.5%. None of the patients with ITC and endometrioid histology recurred, and none of the patients with ITC who did not receive adjuvant therapy or brachy recurred. On the right is a retrospective study that was done on 474 negative sentinel lymph node from 155 patients. They were stained for ITC. ITC was detected in almost 6% of sentinel lymph node and 13.5% of patients. No patient had recurrence after 31.5 months. So the conclusion from that trial is that ITC detection may not be clinically relevant. This is a key Q5 recommendation for patients who have undergone hysterectomy and pelvic nodal assessment with isolated tumor cells. It is conditionally recommended that uterine risk factors be used to guide adjuvant therapy. So if we look at this patient's uterine risk factors, she had stage 1B grade 2, so the recommendation would be vaginal brachytherapy. What is the impact of molecular markers in the management of endometrial cancer? Molecular analysis was performed on all PORTEC-3 patients. Patients with P53 abnormal had the poorest prognosis, with a 5-year recurrence-free survival and overall survival of 48 and 54% respectively. The 5-year recurrence-free survival and overall survival for women with polymutation were both 98%. Patients with MMR deficient and nonspecific molecular profile had an intermediate outcome, as you can see on those curves. The addition of chemotherapy to RT improved outcomes in patients with P53 abnormal endometrial cancer with an absolute benefit of 22.4% and 23% for recurrence-free survival and overall survival, respectively. For polymutation, the outcomes were excellent in both arms, and there was no benefit for MMR deficient. In a recent retrospective study, 2,472 endometrial cancer were assessed and divided into 4 subgroups. Most patients had no specific molecular profile. No benefit was seen for MMR deficient patient, consistent with the findings of PORTEC-3, highlighting that maybe for those patients, we don't need it. So in patients with P53 abnormal, adjuvant chemotherapy and radiation improved disease-specific survival compared to radiation alone in ESMO high risk and ESMO high advanced and metastatic risk groups combined, even when restricted to stage 1 disease and when compared in serous versus non-serous histologies. When comparing outcomes in ESMO high-risk P53 abnormal endometrial cancer according to specific regimens, patients who had received chemotherapy with vaginal cuff and chemo with external beam had the best outcomes, with either radiation alone or chemo alone who were inferior. So, which highlights that the addition of radiation is important in these patients. So what is the recommendation? For patients with endometrial cancer receiving adjuvant therapy, molecular testing is recommended. Immunohistochemistry is needed to assess for mutation in mismatch repair and TP53 genes, and polysequencing can be used to identify hypermutated tumor. And this is a strong recommendation with a moderate quality of evidence. For patients with myoinvasive stage 1A to 3C2, P53 mutated, chemo and radiation are conditionally recommended. For patients with stage 1B to 3C2 mismatch repair deficient tumors, radiation without chemo is conditionally recommended. And for patients with stage 1B to 3C2 polymutant tumors, RT without chemo is conditionally recommended. So this is based on the ASTRO guidelines. So what is the role of immunotherapy in the management of endometrial cancer? So there are 2 studies have been published in the last month, GY018, which is a phase 3 international double-blind randomized placebo-controlled trial that evaluated the efficacy of pembrolizumab in combination with carbotaxol in patients with advanced stage or recurrent endometrial cancer, and advanced stage was measurable stage 3 or 4A. Measurable disease was defined as at least 1 cm on CT. Patients were stratified based on MMR status. Pembro or placebo were given every 3 weeks with chemo and maintenance every 6 weeks for 14 cycles after. And you can see here. So what are the results of this study? The addition of pembrolizumab to standard chemo followed by pembro maintenance resulted in a 70% lower risk of disease progression or death in the dMMR cohort and a 46% lower risk in the proficient MMR cohort. The median follow-up was 12 months for the deficient MMR group and 7.9 months in the proficient MMR group, which is one of the major limitations of the study. A similar study, the RUBY trial, evaluated the efficacy of dostarlimab, an immune checkpoint inhibitor targeting PD-1 receptor. Patients with advanced or recurrent endometrial cancer, stage 3 and 4, were eligible if they were not amenable to curative therapy. So what is the eligibility criteria? It was defined as primary advanced stage 3A, 3B, or 3C1 with measurable disease using RECIST, primary advanced stage 3C1 with carcinosarcoma, clear cell, serous or mixed histological characteristics, regardless of presence of measurable disease. Primary advanced stage 3C2 or 4, regardless of the presence of measurable disease and recurrent disease. As you can see here, 30% of patients had stage 4 and 50% had recurrent disease. Over 80% of patients did not have previous radiation, as you can see here. So most of them did not get radiation, but most of them got surgery. The curves show significant improvement and progression-free survival for both proficient and deficient MMR, and improvement in the progression-free survival for overall population. This is a table comparing the RUBY trial to the NRG GY 018. So as you can see, they have different eligibility criteria. For the GY 018, they have to have measurable disease. For the RUBY trial, for stage 3C1 and high-risk histologies, it was regardless of the measurable disease. So you can see here that the median follow-up for both trials were very short, but they found similar findings. So what is the optimal? So I just want to discuss a little bit those two trials, why I find they're important. I think we're running a little bit out of time. So these might change a little bit the management of endometrial cancer at tumor boards. Now gyn-onc might be a little more willing to give immunotherapy for patients. So how do we sequence it with radiation? What is important to note in these trials is that they did not look at radiation. So these are not trials that show that radiation is not indicated for those patients. I think it's worth reading both trial and looking at them because I think in the next coming months, we might have a shift in how we treat patients, especially locally advanced. I think it is important to discuss it with the gyn-onc tumor board and to understand that this is not a radiation trial. This is more of an advanced, what do we do with advanced disease or recurrent disease, and that immune checkpoint inhibitor might change a little bit the outcomes for these patients, but that does not mean that we should refuse or hold off on radiation. I'm going to quickly discuss the optimal management modality for recurrent endometrial cancer. This was presented recently. This is the results of GOG 238 that looked at the addition of chemotherapy in recurrent disease. And what they found was that there was no benefit of adding chemotherapy. It did not improve outcomes. Most patients had local recurrences, so vaginal cuff recurrences. And as you can see here, the curves are similar. So for those patients with low-grade and vaginal apex recurrences may be best treated with radiation alone. This is just for reference, the JEC ASTRO guidelines for the contouring of recurrent endometrial and cervical tumors in the vagina. Another new study was published, the TOTEM study, which is a large randomized trial to look at how we should surveil patients with randomized between intensive versus minimalist follow-up. And intensive was CT, chest, abdomen, pelvis every 12 months, including pap smear and ultrasound. So as you can see, it depended the surveillance depended on the risk groups. But what is interesting to note is there was no difference in overall or recurrence-free survival between patients with intensive or minimalist, and the probability of detecting a relapse was slightly higher in the intensive group, but was not statistically significant. So the conclusion was that we don't need to order all these exams. We should just order a CT and just follow patients regularly with pelvic examinations. The last The last objective is about ultra hypofractionation for endometrial cancer. This is a trial, but the Spartacus trial, which is a phase 1 and 2 non-randomized trial that looked at SBRT 30 gray and 5 fractions delivered to the nodes and the vagina. They included 61 patients. They had a short follow-up, 9 months, but it did seem that it was well tolerated and there was not a lot of toxicity. Only one patient had acute grade 3 GI toxicity. So thank you so much for your attention. And I look forward to discussing at the Q&A.